Assalamu alaikum. Dear examining committee, today I'd like to present to you my graduation project entitled Cement, Base Materials, and Their New Advancements. One of the aims of the operative dentistry is to preserve the pulp vitality in compromised teeth. So, the method used for this is by using liners and bases, which involves the placement of protective materials on the unexposed pulp to maintain its health and to stimulate defensive repair by tertiary dentine deposition. We'll be starting with some definitions. Liners, which are agents in a volatile solvent, which when applied on a surface it evaporates, leaving behind a thin film. This film acts as a barrier which has different functions depending on circumstance and the location where it's applied. Some of the benefits including the sealing and protection of the dental pulp and can release fluoride and prevent bacterial growth under the restoration. Bases are a layer of insulating, sometimes medicated cement placed in the deep portion of the cavity preparation to protect the pulp from the thermal and chemical injuries. It can also resist the condensation forces on a tooth when placing a restoration. Dental cements are of multiple uses that include restoration, luting agents, and therapeutic agents. They are generally having a comparatively low strength but have an extensive use in dentistry. They can be categorized into temporary or provisional cements, which are placed beneath a temporary restoration between the interval of cavity preparation and the insertion of the final restoration, and also as a permanent cement, which are used for the final restoration. The intermediate filling materials are cavity varnish and cavity sealers. The varnishes are similar to that of a liner, which are a solvent applied on a surface, then the solvent evaporates, leaving behind a thin film which seals the tubules. Therefore, it is considered as a liner also, but it's contraindicated when using resin composite restorations. The cavity sealers are materials that provide sealing as well as bonding on the interface between cavity preparation walls and the restorations. The first material of discussion is zinc phosphate. Zinc phosphate is the oldest of the luting components and thus served as a standard which the newer cements can be compared to. It has many applications like luting of indirect restorations like inlays, crowns, and fixed dental prostheses. It can also be used as a high strength base for restorations. It can be used itself as a temporary restoration and can be used for luting of orthodontic bands and brackets. It's available as a powder and liquid form and also as a capsule of pre-proportioned powder and liquid. The mixing method for zinc phosphate should be performed in a cold glass lab that promotes the cooling of the exothermic reaction that occurs when the powder and liquid are combined. And also, the more powder added, the greater the physical properties of the cement. The next material of discussion is polycarboxylate cement, which is developed by substituting the phosphoric acid of the zinc phosphate cement with polyacrylic acid. It has very similar applications to that of zinc phosphate, but is primarily used for luting of permanent restoration. It's available as in a powder and liquid bottles and as a water-soluble cement. The mixing method for polycarboxylic cement should be performed for prepared cavity by placing 3 increments of powder with 3 drops of liquid and combining each one slowly and spatulating until getting the wanted consistency. And for the cementation of crowns and PFMs or porcelain fused metals, the polycarboxylate cement must be allowed to set while metal and prepared tooth surface are compressed together. So, for this reason, it is advised that the patient bites hard on a cotton roll without relaxation until the cement is set, thus by removing the excess and thinning the film so it proves the bond. The next cement or material in discussion is calcium hydroxide, which is a very popular material. It is relatively a weak cement and commonly used as a direct or indirect pulp capping agent. They also serve as a protective barrier against irritants from certain restorations and many other applications like epixification and in pulpotomy as an intracanal medicament and can be used as an endodontic sealer. It has many forms, like a toothpaste system like Dicol, which is a very popular material, as in light cure system, as a single paste syringe form, also can be available in a powder form, mixing it with distilled water. The light activated calcium hydroxide cement have a longer working time and less brittle than conventional toothpaste system. It's radio opaque and supplied in a syringe form. The next material of discussion is a very popular one, is zinc oxide eugenol cement. It's a relatively weak cement, but it's been used extensively in dentistry since 1890s. It is the least irritating of all dental cements and known to have an obtundant or sedative effect on the exposed dentin. It is classified into type 1 for temporary cementation, which from 1 to 6 weeks, and type 2 for base and temporary restoration. It is used from few weeks to few months. The mixing method for zinc oxide eugenol should be performed by adding powder and liquid together by small increments while vigorously spatulating until getting the desired consistency. The clinician should be aware of the ambient condition because humid environment can cause the reaction to speed up. The next material, which is the most popular and used material in dentistry, is glass ionomer cement. Glass ionomer cements are adhesive, tooth-colored anti-cariogenic materials which were originally used for restorations of eroded areas. The current glass ionomers have been modified to allow a wider application, and this cement requires minimal cavity preparation. That's because it bonds adhesively to tooth structure. It's known as a biomimetic material because of its similar mechanical properties to dentine. For this reason, it's one of the most popular cements in dentistry. Some of the applications for glass ionomer cement, or GIC for short, is using it as a restorative material for class 3 cavities, for class 5 cavities in eroded areas, can be used as a luting agent, as a liner, a base, core build-up material, and as a limited extent for pit and fissure sealant and many other applications. It is classified based on the consistency and the powder liquid ratio into a luting agent, a base and liner, and a restoration material. It can be also classified into the conventional GIC, a resin modified GIC, or a metal modified GIC. GIC is composed of a powder and a liquid. The powder is an acid soluble calcium fluoroaluminosilicate glass, which is similar to that of silicate, but it has a higher alumina silica ratio, so this increases its reactivity with the liquid, which is originally composed of 50% aqueous solution of polyacrylic acid, but this composition made it very viscous and has a tendency to become a gel. So modern glass ionomers liquids are in the form of copolymers. Some of the properties of GIC, like the mechanical properties, is very different because of the different powder liquid ratio for different applications, so it shows variation in their physical properties. But in general, hardness is far lower when it compared to composites, and it is susceptible to abrasion and occlusal wear when compared to composites. Solubility and disintegration is high due to the leaching of intermediate products, which happens within the first 24 hours of the placing of GIC. GIC adheres well to enamel and dentine. This bonding is due to the reaction between the carboxylic groups of the polyacids and the calcium in the enamel and dentine. So, the bond between the GIC and enamel is way higher than that of dentine, that is due to the greater inorganic contact in enamel. Aesthetically, it is inferior to that of silicates and composites, so they lack the translucency and have a rough surface, so they may stain with time, but aesthetics are sufficient for restoring cervical lesions with minor defects in non-aesthetic zones. The biocompatibility is considered relatively biocompatible, but the pulpal response also considered to be mild, so it is relatively biocompatible. GIC has some anticarcinogenic properties because it releases fluoride initially in amounts comparable to that of silicate cements and continues to do so over an extended period of time. The newer advances of glass ionomer cement was needed because conventional GIC lacks sufficient strength and toughness. So, in order to improve the mechanical properties of conventional GIC, resin modified glass ionomer was introduced, which contains hydrophilic monomers and polymers like hydroxyethyl methylacrylate or HEMA for short, and they have a higher flexural strength when comparing to that of conventional GIC. And many other modification was introduced that will be discussed in the next slides. First of all, the resin modified glass ionomer or RMGI for short. These materials were introduced to overcome the drawbacks of conventional GIC like moisture sensitivity, like low initial strength, and a fixed working time. The similar uses of GIC and RMGI, but there are different uses, like in the use in restoration of class 1 cavities and the repair of damaged amalgam cores or cusps, or as a retrograde root filling material. Another advancement in the GIC manufacturing and production is the introduction of glass carbomer, which glass carbomer cement contains nanosite powder particles and hydroxyapatite and fluoroapatite as a secondary filler. This have been introduced with the claims in the improved physical characteristics in comparison to that of conventional GIC. Another advancement is the introduction of bioactive glass. What is bioactive glass? Bioactive glass bonds to both hard and soft tissue. So, a material is said to be bioactive if it gives an appropriate biological response and result in the formation of a bond between material and tissue, in addition to that, to remineralization. So, the combination of bioactive nanosilica with dental cements improves the biocompatibility, which is helpful to overcome the marginal gap formation, which is a major disadvantage in many dental cements. Bioactive glass has been used as a restorative material in treating dentine hypersensitivity and promoting enamel remineralization. Another advancement in the manufacturing of GIC is the introduction of casein phosphopeptide and amorphous calcium phosphate complex, short for CPP and ACP. ACP is the initial solid phase that precipitates from a highly supersaturated calcium phosphate solution, while CPP is a milk product which helps in a remineralization and helps in the prevention of dental caries. So, the advancement happened when incorporating 1.56% of the complex into GIC, which significantly increases its tensile strength, compressive strength, and also significantly enhances the release of calcium, phosphate, and fluoride ions at neutral and even in acidic pH. Another major advancement happened in the introduction of zirconomer, also called as white amalgam. The inclusion of zirconia fillers in the glass component reinforces the structural integrity of the restoration material and impairs higher mechanical properties. So, the combination of outstanding strength, the durability, and sustained fluoride release deems it the ideal restorative material for posterior teeth. And the last advancement we're going to talk about is the nano bioceramic impregnated GIC. The addition of nanofluoroepitide to the powder component of conventional GIC has a positive impact on its compressive, tensile, and flexural strength of the set cement. Also, the addition of titanium oxide nanoparticles to the GIC powder has shown to improve the mechanical properties and the antibacterial effects of the set glass ionomer cement. So, doping conventional GIC with nano-sized particles, glass particles, can decrease the setting time. Thank you for your attention, and special thanks to my supervisor, Dr. Mervet, for her continuous support.